Good morning. Welcome to Unacademy, where you can crack all NEET PG exams with us, with our top educators, quality content, and you all can have a great learning experience with, and have a great learning experience with us. So, guys, let's crack NEET PG. I'm Dr. Sasha Remedies, and I'll be taking your class today. A little about me. I've done my MBBS from Father Muller Medical College, Mangalore, and MD in Anesthesia from the same. I have 2 publications and 1 paper presentation in the field of anesthesia, and I've been working and teaching in Bangalore for the past 2.5 years. So today's topic will be opioids pharmacology. I'll be taking it in 2 parts. I'll be dealing with the first part today, right? Now, crack NEET PG with us on India's largest learning platform, that is Unacademy, where you get plus subscription and you can access unlimited live and recorded classes, courses from India's best educators. So guys, don't delay, get your subscription. We have 3 types. Get your subscription. We have 3 types of classes: your YouTube, your special classes, and your subscription classes. Subscription classes is what you need to subscribe for. The special classes platform is also a very attractive platform, and we have classes there too, as well as on this platform, that is a YouTube platform. Now, what will you get out of Unacademy? So we have our daily live classes where you can chat with your educator, engage in discussions, and ask your doubts and answer polls, all while the class is going on, right? So the thing over here is, a normal coaching class, you waste a lot of time. So you have to travel to your coaching class, it wastes your energy, it wastes your time. Once you reach your coaching class, it's a large class, there are so many students there. You cannot clear your doubts always, right? It takes time. Like, it's not like your educator can clear everyone's doubts. So he or she might be able to clear your doubts, might not be able to clear your doubts. So it's all a harrowing process. But over here, you can chat with your educator, engage in a discussion, clear your doubts then and there. And your educators are well prepared. They try their best to clear everything. They will get back to you if they cannot clear a doubt for you. So it's all to your benefit. We have structured courses. That is, all the courses are structured in line with your PG syllabus, and this helps you best prepare for it, right? So they're all in line with your exam syllabus. Then we have our live tests and quizzes, which help you evaluate your preparation with our regular mock tests, our quizzes. So we regularly, based on our topics, we will conduct tests and quizzes, and we'll go through the tests and quizzes with you all, so that you all get, so we'll cover a set of topics and then give you all tests and quizzes on those topics, so that you all are better prepared, right? Then you all have unlimited access. So one subscription can get you access to all, whatever, the live classes, the recorded classes, the quizzes, the tests. So it's just one subscription and you have access to all these things. So guys, get your subscriptions, don't delay, start preparing. It's a vast subject, MBBS as such, to prepare for your NEET PG, right? So start preparing, get your subscriptions, let us help you. These are some of our top educators on the platform: Dr. Nikita Nanwani, Dr. Mohammad Azam, Dr. Devish Mishra, Dr. Preeti Sharma. These are the courses offered. So there are 19 subjects, as you can see, and there are different courses under these subjects, and you can refer to any of these courses, go through them. There are the times are previously put up. Sometimes we're late, like today. I'm so sorry guys, I got a little late, there was some issue, but most of the time we're on time. Almost all the time we're on time, and so it's all structured for you. It's all right there for you. We're helping you all prepare. So subscribe, guys. These are some of the ongoing courses on our platform. That is your GI surgery, cardiovascular thoracic surgery, course on the larynx, respiratory system, neurophysiology, pathology. These are all the various courses that are ongoing on our platform. Now, coming to the most important part, the subscription. As you can see, there are 5 types of subscription, but I would highly recommend that you all go for the 12 and the 24-month subscription. Now, why would I say that? So as you can see, NEET PG 19 subjects, such big, vast topics. Under each subject, the topics themselves are so vast. Forget the number of topics. Each topic is so vast, so much to cover. 6 months and all it's really not feasible to cover 19 subjects. I'm not saying it's impossible, but it is a little tight. So if you need your 12 months, which is a perfect period, and to cover that these subjects, so that's why I recommend the 12 and the 24 months subscription. Because even if you don't get through, okay, suppose you're just answering NEET in 3 months, fine, take the 12-month subscription. Even if you don't get through, you still have the 12 months. So it's a one-time subscription. So you do your 6-month subscription, 3-month subscription. After 3 months, you have to pay again, right? You need to pay again because it's a one-time subscription. But with your 12 and 24 months, it continues. It's there for whatever duration you have paid for. So guys, you use my code, as you can see, SASHA at the bottom of the screen in red, and subscribe. Hurry, don't delay. Also, it's more economical. Now, why is it more economical? So you can go for the 24-month too. Like I said, if you need to, some people need 2 years to prepare. You might not clear on the first attempt. Fine, go for it. Nothing wrong. Knowledge is always good. So whatever knowledge you gain in 2 years, it's not a waste. It's like amazing. It's the best thing that can happen to you, literally. So as you can see, I can use my code at the bottom of the screen, SASHA in red, and subscribe. You'll get your 10% discount. So if you use my code, you get a 10% discount. So please guys, subscribe. Also, like I said, more economical because it's a one-time subscription. So once your period is over, you need to subscribe again if it's a short period. But 12 and 24 months, unlikely. Come on guys, we are here to help you crack it. We will help you crack it. So please do subscribe. 12, 24 months, ideal. So coming to today's topic, opioids. So this is basically on the outline on the two classes. I'll be dealing with the definitions, a little bit on history, endogenous opioids, opioid receptors, pharmacokinetics, pharmacological effect profile, the classification of opioids, that is your pure agonist, agonist, antagonist, and antagonist. The clinical pharmacology, that is the therapeutic use of opioids in pain control, guidelines for opiate dosing, non-analgesic uses, acute opioid toxicity, and screening methods. Okay, so I'll be taking the class in 2 parts, okay, and I'll be covering all that in these 2 classes. So today and tomorrow, my tomorrow's class, the continuation of this class will be at 7:30 p.m. in the evening, not in the morning. It will be at 7:30 p.m. in the evening. So guys, let's deal with the first part of the class today. Okay, let's get going. So the introduction. Now, what are opioids? Okay, it comes from the Greek word opos, which means juice. Okay, it is any substance, regardless of its origin or structure, that produces morphine-like effects that are blocked by antagonists such as naloxone. So morphine-like effects blocked by antagonists such as naloxone. So naloxone is an opioid. Yay, my pen is working well today. Huh? Sometimes I have so much of a problem with this. Okay, so it is an opioid antagonist. Okay, now opiates include natural, so this is opioids. So any substance, regardless of its origin, that produces morphine-like effects, which I'll be dealing with eventually in the class, that get blocked by naloxone are known as opioids. Okay. Now, opiates include natural alkaloids derived from the resin of the opium poppy. Poppy is a flower, right? I hope you all know that. It's a flower. It's a red. You get even pink and I think yellow too. I'm not too sure, but red and pink is definitely there. So it's a natural alkaloid which is derived from the resin of the flower poppy. Okay. Now, some authors also include the semi-synthetic substances derived directly from these alkaloids. Right? So, some substances also include the semi-synthetic. Some authors include the semi-synthetic substances derived from these alkaloids. So Opiates are generally natural alkaloids, but some authors also include the semi-synthetic substances that come from these alkaloids. Now, what is a narcotic? So, any substance which induces sleep, any substance which acts on an opioid receptor, any illicit substance, legally opium derivatives, and the semi-synthetic derivatives. So, these all encompass narcotic. It comes from the Greek word narcos. So any substance which induces sleep. So the narcotic should induce sleep. It should act on the opioid receptors. It has a dependence. It's an illicit substance because, so why is it illicit? It causes dependence. Okay, substances which cause dependence cannot be used. So illicit substance because it causes dependence. And it can be used legally too. So legally, basically, I'm sorry, legally, why is it used legally? It is used for cancer, pain and all that, right? So basically, any chronic pain, it is prescribed legally. So chronic pain syndromes is where it is prescribed legally. And now the oldest opioids are the oldest known drug to mankind. It was discovered by Sumer in 4000 BC. Greeks, this is just like little knowledge for you all, that's all. Theophrastus in 3rd century BC, from then it's been there. Arabic physicians, it was used for asthma, bad eyesight, diarrhea and euphorin. So it was used for everything because it was the oldest drug prescribed. So they thought that it would, so basically they thought that it could be used for everything. So they used it for everything. Opium addiction, basically it was a lifestyle statement in the 17th and 18th century which has continued. It was a source of an important social problem, one of the first public health concerns known as baby doping. Okay, so basically it was giving child an opium to keep them quiet. So basically because of their withdrawal, they used to be given this opium. It was like baby doping to keep them quiet, and it was a public health concern. Now, Frederick Sertner isolated the crystalline pure substance from opium that he named morphine. Comes from the Greek word Morpheus, which means god of dreams. Well, it does send you into that kind of universe where you have these, you're on a high. It makes you feel good about yourself and all. So basically God, so god of dreams, because you're sedated, you're like totally amnesia, anesthetized. So it's like god of dreams. Arnold Beckett proposed that morphine-like compounds act by binding to specific receptors in the brain. So this gave rise to your opioid receptors. So now coming to the endogenous opioid system. So what is it? These endogenous opioids are basically already present in our body, right? So endogenous, within our body. So basically endogenous is within our body. So the distribution of cells producing these three different types of endogenous opioids vary. Okay, so it is the these opioid cells are distributed throughout the body, right? So they are present in the arcuate nucleus and in the hippocampus. So basically these are located in the areas of the brain related to pain producing pathways in case of pre-pro-enkephalins. So basically the endogenous opioids are the dynorphin, enkephalin and endorphins, right? So the wider distribution, so there is a wider distribution in case of pre-pro dynorphins. Basically in case of dynorphin there's wider distribution. So endomorphin is a newly discovered endogenous opioid with atypical structure and selectivity towards the mu receptor. So that's a mu receptor is an opioid receptor. Okay. So basically the endogenous opioids are dynorphin, endorphin, and enkephalin. Okay. So these are your endogenous opioids. This endomorphin is a newer opioid with atypical structure and selectivity towards the mu opioid receptor. There is uh, another novel endogenous peptide which was derived from dinorphin. Okay, it was synthesized in 1995. It is known as orphanin FQ or nociceptin. Okay, it acts on sites other than these endogenous peptides. Okay, so this is a newer endogenous peptide. So function of endogenous peptides is it is modulation of pain perception, modulation of motor activity for sustained periods, that is your runner's high, that is the feeling of adrenaline rush after you're running. You don't feel it when you're running, but once you stop running you feel uh, so it's basically a feeling of more energy after you finish your run. So when you're tired, you go for your run, there's an adrenaline rush, there's modulation because of these endogenous opioids are released, there's modulation of motor activity and you feel a high and autonomic regulation. Now coming to your opioid receptors, okay, there are three types: mu, kappa and delta are the three opioid receptor. Okay, so mu was named because they were morphine type. So they are distributed throughout the brain and spinal cord, and also they are seen outside the CNS. So these opioids have action brain, the spinal cord, and also outside the CNS, that is your vascular tissue, immune system, gut, airway, lung. So these receptors are also located there. So your mu receptor, it was named because of because of morphine type. They are similar to the action is similar to morphine. Then we have the kappa receptor. It was named because of the ketocyclozocin type. Okay, ketocyclozocin type. These were all derived from pharmacological experiments. Okay, and then you have your delta, which was named from your allyl normetazocin. Sorry, metazocin. Okay, so these are the three types of opioid receptors, and based on how these have been named. Now they belong to the rhodopsin family of G protein coupled receptors. Okay, so they belong to the rhodopsin family of G protein coupled receptors, and they are distributed throughout the brain and the spinal cord, and also outside like I said. So they are present throughout the brain, the spinal cord, and outside the CNS, which includes your vascular tissues, your cardia, your lungs, gut, and cells of the immune system. So they have various, because the receptors are present everywhere, they produce various effects and side effects on these various parts of the body. Now the opiate receptor like protein with an endogenous ligand, like I said, this is a newer uh, receptor. So this is the ORLP1 or NOP1 is the opiate receptor, which is for the ligand nociceptin or orphanin FQ. So this is a little on about the uh, regulation, how the opioid intracellular, so this is basically the intracellular signal transduction. This is intracellular signal, intracellular, this is a model of intracellular signal transduction. Intracellular signal transduction mechanism that is associated with your opioid receptors, right? So, whenever there is a opioid receptor activation, okay, as you can see, the G protein, so the opioid receptors, first of all, like I said, belong to the G protein receptor family. Activation of the opioid receptor leads to activation of the pertussis toxin sensitive G protein. So activation of this opioid receptor will lead to activation of the G protein coupled receptors. That is, these are your G proteins. So these are the pertussis toxin G protein coupled G proteins. Then so what happens with this adenylate? So it stimulates potassium channels. It causes activity of adenylate cyclase, and voltage gated channels is suppressed. So your adenylate cyclase channeling is suppressed. So there is no conversion of ATP to cyclic AMP. So this cyclic AMP is not produced. As a result, there is no regulation of the Krebs cycle does not occur. There is inhibition of the calcium channel. So the inward flow of calcium channels is inhibited, no depolarization. The potassium channels are stimulated, of course, and so this is how the opioid receptors act, right? Bring about their function. Now, when there is chronic exposure to morphine, okay, there will be opioid receptor phosphorylation. Okay, uh, this is basically a mechanism which leads to internalization of the receptor. Okay, so this chronic exposure to an agonist induces cellular adaptation mechanisms, which are so these mechanisms are involved in opioid tolerance. Okay, so chronic exposure induces some cellular adaptive mechanisms which may be involved in opioid tolerance, dependence, so involved in opioid tolerance, dependence, and withdrawal. Okay, so this long-term exposure leads to certain changes, basically internalization, which which is governed by phosphorylation of the opioid receptor, which causes tolerance, dependence, and withdrawal. So when this phosphorylation occurs, various kinases get activated. Okay, uh, beta adrenergic receptor kinase, which is a member of the G protein coupled. So the bark, basically beta adrenergic receptor kinase, this gets activated, which leads to the formation, which leads to this beta, leads to this beta arrestin signaling. So this is a kinase, that is your beta adrenergic kinase. It selectively phosphorylates the agonist bound receptors and thereby promotes the actions of beta arrestin, which interfere with G protein coupling and promote receptor internalization. So this protein kinases, whenever there is long-term exposure, long-term chronic morphine exposure, it stimulates this beta adrenergic receptor kinase, basically the kinases, even protein kinase. This leads to stimulation of this phosphorylates the opioid receptor and activates the beta arrestins, which interfere with the coupling and promote internalization. Okay, so it beta, so this receptor is basically involved in, so basically your Krebs cycle will gets inactivated, right? And activation is, so the regulation of it is also involved in the regulation of the receptor. That is how the receptor is basically so what happens, how the receptor gets what you call it, how it is recycled. So beta arrestin is one is it is involved in the tolerance, dependence and withdrawal through the beta adrenergic receptor kinases whenever there is long-term chronic exposure of an agonist because of phosphorylation. Then this beta arrestin 2, okay, out of this beta, so there is a beta arrestin 2. So this beta arrestin 2 is involved in the opioid receptor recycling, signaling and degradation. So it is involved in recycling, signaling and degradation. So this is how your beta arrestins function. Two mechanism, your recycling, signaling and degradation, and also by causing phosphorylation of the receptor which is exposed for a long time to an agonist, leading to tolerance, dependence and withdrawal. Okay. Now these are some of the action of the mu receptors. So the mu receptors, as you can see, there are two types of mu receptors, mu1, mu2, the kappa receptor and the delta receptor. So the mode of, I'll be coming to this analgesia, how it is produced, but as of now the mode is of analgesia is supraspinal in mu1, and in mu2 it is spinal. So supraspinal is basically it is in the cortex. Here the action is at the spinal cord. Okay, the kappa receptor has action both supraspinal and spinal. The delta receptor has supraspinal, spinal, and it modulates the mu receptor activity. On the cardiovascular effects, as you can see, is bradycardia in case of the mu receptors. The kappa receptors do not have any effect on the kappa and delta receptors, do not have any effect on the cardia. Now the respiratory effects, the mu2 causes respiratory depression, and as it is same with kappa and delta 2. In general, opioids cause respiratory depression. Central nervous system, so your euphoria, sense of elation, sedation, prolactin release, hypothermia, catalepsy, and indifference to the environment is caused by mu1. Your mu2 leads to euphoria, dopamine turnover, so there is increased dopamine release, which leads to your mood alterations, which is one of the effects of opioids, mood alterations, and possible growth hormone release. Kappa receptor leads to sedation, dysphoria, there is no euphoria, and hallucinations, your psychomimetic action, that is hallucinations, delirium, is produced by the kappa receptor. Delta receptor as such does not have any CNS symptoms. Pupil, it causes meiosis in all three types of receptors except the delta receptor. GI effects, because of the mu receptor, it inhibits inhibition of paralysis, of peristalsis, leading to nausea and vomiting. This is not seen with mu1, kappa and delta receptors. Genitourinary, the mu receptors lead to urinary retention as well as the delta receptor too, but the kappa receptor leads to diuresis because of inhibition of vasopressin release. Okay. Pruritus, it is seen with your delta receptor as well as your mu2 receptor. Physical dependence, mu1, basically those that act primarily on the mu1, which is rare, have low abuse potential. Even on the kappa receptor agonist, so basically the drugs are modified to be only kappa receptor agonists like that because of the low abuse potential. So now coming to the pharmacokinetics, it is opioids are, I'll be coming to them individually too in my next class, but this is briefly on the metabolism, on the absorption, on the pharmacokinetics, right? So it's modestly absorbed through the GI tract. Okay. So modest absorption through the GI tract, oral as well as rectal routes. So it's absorbed through the GI tract, oral as well as rectal routes. Absorption depends on the lipophilicity. It has a high first pass metabolism. Morphine's bioavailability is only 25% by the oral route. Well absorbed through the subcutaneous and IM routes can also be used, and through nasal snorting, basically nasal insufflation, rapid rise in blood levels are seen. So there is subcutaneous, intramuscular route, the GI route, oral as well as rectal. They have a high first pass metabolism. This absorption depends on the lipophilicity. There's only 25% bioavailability by the oral route, but nasal insufflation can lead to a rapid rise in blood levels. And now coming to the distribution. So 1/3, so morphine is basically the base drug, the drug. So 1/3 of morphine is plasma protein bound. They achieve high concentration in highly perfused tissues because of the blood supply, right? So high concentrations will be achieved in the brain, kidney, liver, spleen. Chronic administration can take place, and when chronic administration is there, opioids are found in the blood long after the dosage has been stopped. So 1/3 out of the morphine, 1/3 is plasma protein bound. This 1/3 plasma protein bound. High concentrations because in perfused tissues, and chronic administration, opioids are found in plasma even after drug has been stopped. Now metabolism in the liver, so morphine undergoes glucuronidation into morphine 6 glucuronide and morphine 3 glucuronide. Okay, these have significant activity themselves. So these metabolites of morphine that undergo live in the degradation, morphine 6 glucuronide and morphine 3 glucuronide. Okay, all the morphine cogners like heroin, codeine, fentanyl are also degraded in the liver by the cytochrome P enzymes. Okay. So they're based on the liver function, their activity will be increased and decreased. Now, how are they excreted? Morphine 6 glucuronide and morphine 3 glucuronide, which are cogners of morphine, they are metabolites of morphine, are excreted by glomerular filtration. So chronic renal failure can cause elevated levels of these metabolites and lead to adverse effects such as seizures, CNS depression, okay, because of metabolites in accumulation of, so these metabolites, morphine 6 glucuronide and 3 glucuronide, excreted by kidneys. Now coming to the pharmacodynamic effect profile of clinically used opioids. So basically this includes your mechanism of action too, that is how your opioids act. So basically remember, opioids on the central nervous system, how is analgesia produced? So basically the analgesic effect of intravenous opioids are because of two processes, right? So when given to patients in pain, the patients find the pain less intense. It's not that the pain decreases, the patients find the pain less intense, tolerable, and they feel more comfortable with relief of distress. When given to normal patients, they frankly feel unpleasant because you feel drowsy, difficult in mentation, less physical. So you feel impaired. It feels like, you're like, you feel sleepy, you feel apathy. Though you're feeling good about yourself, but you still are. Your senses are depressed. But in a patient with pain, the pain tolerance, they feel more comfortable. There's relief of distress. So these people really feel good, and hence there is a high tendency for dependence. So the analgesic effects of intravenous opioids are the result of two related processes. That is, there is direct inhibition of ascending transmission of nociceptive information from the dorsal cord of the dorsal horn of the spinal cord. So this is the analgesic effect of intravenous opioids, is because of two related processes. That is direct inhibition of the ascending transmission of nociceptives from wherever the pain is. So this is your brain. So there is direct inhibition of this from the dorsal horn of the spinal cord, right? Okay. The activation of descending pain control circuits from the midbrain to the dorsal horn of the spinal cord. So any pain sensation which is this is your stimulus. So any pain sensation going to the from the dorsal horn of the spinal cord to the brain is inhibited, and there is activation of the pain control circuits that come from the midbrain to the dorsal horn of the spinal cord. So there are different pain states. Okay, analgesia, there are different pain states. One is acute nociception, acute pain, and another is the chronic pain or the nerve pain. So your acute nociception is because of activation of small high threshold sensory afferents, that is your A delta and C fibers, right? So your A delta and C fibers, basically, then from there, these sense your small high threshold sensory pain, like a needle prick, incision, any hot, like when you keep a hot plate on your hand. So these are small high threshold, small pain stimulus, like acute pain they are, right? It's not chronic pain, it's not a nerve pain. So the A delta and C fibers, from there they go to the spinothalamic tract. From there they go to the limbic system, that is your anterior cingulate cortex. Okay, so that is how acute nociception pathway is. A delta C fibers from the site of nociception, acute pain, goes to your spinothalamic tract. From your spinothalamic tract, it goes to your anterior cingulate gyrus, which is in the limbic system. Now here is your tissue injury, that is your acute pain. So whenever there is a tissue injury, like your burns, or basically your burns, any burns, abrasions, joint inflammation, musculoskeletal injury, so any tissue injury, there will be local release of active factors, your prostaglandins, bradykinin. Okay, so there will be local release. Persistence of these inflammatory mediators causes sensitization of the A delta and C fibers. This through the ascending pathway through the spinothalamic tract, it leads to spinal facilitation, that is, it is exaggerated in the spinal cord, and exaggerated output. So because there is facilitation in the spinal cord, there's exaggerated output for the pain. So that little pain, acute pain, it is a small, it is actually a small stimulus that is, but it, because of the spinal facilitation in the dorsal horn of the spinal cord, it in the cortex, it gets magnified, and it is perceived as ongoing pain and hyperalgesia. Now, nerve injury. So this is your chronic pain. Okay. So there is, in your chronic pain, there is activation of A beta. Okay. So this will be nerve compression, chemotherapy, diabetes, etc. is your chronic pain syndrome. So whenever there is a nerve injury, there will be peripheral nerve degeneration leading to the formation of a neuroma. Okay. So this neuroma then will lead to spinal sensitization again, or through the A beta fibers. So will lead to the spinal sensitization, and the stimulation of A beta fibers will lead to allodynia, that is light, even a small, this is just touch hurts. Okay, that is the acute pain is actually a noxious, minimal noxious stimulus which is perceived as hyperalgesia. But here it is even light touch will hurt, right? There can be spontaneous afferent activity as well as because of spinal sensitization. There will be spontaneous dysthesias, that is, there will be shooting burning pain. Okay, this nerve injury, it's just a minor injury like your stump injury and all that, right? After amputation, it will be a shooting burning pain because of spontaneous efferent activity, the spontaneous activity of the efferent fibers that have been cut off in an amputation, as well as spinal sensitization. Now, what are the analgesia mechanisms? Okay, so analgesia mechanisms are the periaquidal, the uh, periaqueductal gray matter, preaqueductal, sorry, the periaqueductal gray matter, right, is where there will be opioid action. Okay, this is a supraspinal effect. Okay, so the periaqueductal gray, there will be the GABAergic neurons. This is inhibited by the mu opioid receptors. MOR is your mu opioid receptor. Yeah. So, uh, the opioids, they act at the periaqueductal gray. They influence the rostroventral medulla, which in turn modulates the nociception in the dorsal horn of the spinal cord through the action of the descending inhibition pathway. Okay, so they inhibit the GABA release. GABA is a inhibitory neurotransmitter. Yeah, so it inhibits GABA release. Mm. So there is decreased inhibitory effects going to the spinal cord, and it brings about analgesia. Now the spinal, how does the mu receptors bring about at the spinal cord? So at the spinal cord, opioids act at synapses either presynaptically or postsynaptically, and they are abundantly expressed. So opioid receptors are abundantly expressed in the substantia gelatinosa of the spinal cord. So they are abundantly expressed there, and they act in the substantia gelatinosa, uh, uh, where it inhibits substance P, which is responsible for your pain. So in the substantia gelatinosa, it inhibits substance P, it inhibits the calcium channels, facilitates the potassium channels as well. As a result, in the substantia gelatinosa, inhibiting substance P and brings about the spinal opiate action. Now, peripheral mechanisms of analgesia. So based on so they may produce through the immune cells infiltrating the inflammation side, they may release endogenous opioids, or in the primary sensory neuron they might be endogenous opioid release. So these are all peripheral mechanisms, but it is not proven. So the opioids also, they have said to be having, so this is basically all the midbrain, right? But even in the forebrain, they are said to have an action. Okay, opioid receptors are even said to be found in the forebrain. And peripheral mechanisms, like I said, the immune cells that are released might have some release endogenous opioids, but it is not proven. Uh, so the basic tenet is they act centrally, spinal cord and on the in the cortex, supraspinal. But recently, in conditions of inflammation, it has been found that opioids can act directly even on peripheral terminals of small afferents, but it is not yet fully proven. Now, your mood alterations and rewarding properties, that is, the opioid receptors are said to be concentrated. All three receptor types are said to be present on the nucleus accumbens and are thought to mediate the motivational effect of opiate drugs. Mu and delta receptors are more rewarding, okay, when intracranially administered. Basically there is more mu and delta receptor action, but all three are said to be involved. These two receptors, when the drug binds, they definitely have a positive stimulation. The kappa receptor can have a negative, can bring about negative effects, okay. So the nucleus accumbens is the your amygdala, nucleus accumbens, hippocampus. This is all in your prefrontal cortex, are said to be the mood altering and rewarding properties. Nucleus accumbens being primary. Okay, this it causes increase in the dopamine release in the nucleus accumbens, which helps in elevating mood. So coming to CNS depression, now your respiration. So your respiratory depression is a primary cause of morbidity secondary to opioid therapy. Okay. So all phases of respiratory activity, that is your rate, minute volume, tidal exchange, all are depressed, and it can lead to aperiodic and irregular breathing. Now direct depression of rhythm generation in ventrolateral medulla and desensitize so it causes a depression of rhythm generation in the medulla, desensitization of the brainstem chemoreceptors, which normally respond to a high PCO2 levels, carbon dioxide levels, and also they desensitize chemosensors in the carotid and aortic bodies, which usually respond to hypoxia. So basically there will be no response to increasing carbon dioxide, no, because of the desensitized chemoreceptors, no hyperventilation. So the respiration is depressed, the rate of ventilation is decreased. Hence, there is no response to PCO2 because of respiratory depression. Also, there is no response to hypoxia. Again, when there is hypoxia, there is a, because of the carotid and chemoreceptors, there is a baroreflex phenomena which will not occur. Effect on cough. It is a direct inhibitory effect on the cough center. Hence, opioids like codeine are used as antitussives, that is your anti-cough agents for dry cough, wet cough. Dextromethorphan and codeine, codeine. So there is no loss of protective glottic function, even though they depress the cough center of the medulla. And there is no relation between the suppression of cough and respiratory depression. There is no relation between the two. So it will not cause respiratory depression if it is suppressing cough. So opioids also, there is no increase in ICP. They bring about no increase in ICP. They decrease the cerebral metabolic rate. And if decrease in ICP can be seen, but generally nothing is brought about, but the decrease in the cerebral metabolic rate is seen. Okay, they cause basically vasoconstriction in the brain. Now, effect on nausea vomiting. It causes direct stimulation of the CTZ, the CTZ center in the brain, which is the center for your nausea vomiting. So it causes direct stimulation of it. A vestibular component 2 is involved. This can be in your ear. The vestibular component 2 is also involved. Apomorphine, which is a cogner of morphine, is highly emetic but has no action on opioid receptors, right? So there are stimulation of the CTZ and vestibular component. So 5-HT receptor antagonists are used for opioid. This is the treatment. 5-HT receptor antagonists for opioid induced nausea and vomiting. Seizure and convulsion. Some opioids at slightly higher doses can produce epileptogenic. They can produce epileptogenic activity, like your meperidine. Frank seizures and myoclonus can occur. So pethidine. This is basically pethidine. The metabolite of pethidine, norpethidine. Norpethidine is known to have stimulates convulsions. Okay. Several mechanisms. They are inhibition of the inhibitory neurons, that is GABA, direct stimulatory effects, and actions mediated by non-opioid receptors by their metabolites. So the metabolites act on non-opioid receptors. Other effects are temperature regulation. There can be a slight fall in body temperature. In withdrawal, there will be a rise, but otherwise there will be a slight fall in body temperature. Meiosis, through the parasympathetic stim pathways, uh, uh, they cause release of cortical inhibition on the Edinger-Westphal nucleus. So the GABA inhibition is removed on the Edinger-Westphal nucleus, which leads to meiosis. This is also a very last action to develop tolerance. Opioids are known to have tolerance, and meiosis is a very last action to develop tolerance. Motor tone. So high doses can increase the motor tone. They can cause chest wall rigidity, increase for myoclonus. Okay. This does not facilitate muscle relaxation or anything. Okay, nothing like that. It is not muscle relaxation. It's not acting at the neuromuscular junction. It is just causing an increase in the muscle tone, chest wall rigidity, and but pre-treatment with the it is similar to neuromuscular blocking effect. Pre-treatment or concomitant on or concomitant treatment, that is along with when you're giving the opioid together with or pre-treatment with the muscle relaxants. Okay, decreases this rigidity. With muscle relaxants is known to, in subanesthetic doses, is known to decrease this rigidity. Now, some of the peripheral effects on opioids. So, opioids block the release of many hormones of the hypothalamic pituitary axis. That is, it causes adrenal and on the effect of adrenal and sex steroid hormones. There is a decrease in the release of testosterone, DHEA, that is a precursor of testosterone, cortisol, and also the gonadotrophins from the pituitary. Uh, and this is direct effect on the pituitary and also indirect effect on the hypothalamic neurons, leading to decrease in these hormones. It can lead to endocrinopathies, hypogonadotrophic hypogonadism, decreased libido, uh, menstrual irregularities, effect on sexual characteristics. This is all when taken in excess, right? Not with normal anesthetic doses. These are side effects of drug abuse. Okay. Prolactin, increased secretion due to loss of inhibitory control of dopamine, right? There is excess dopamine produced, excess prolactin secreted. Oxytocin and vasopressin, the kappa opioid receptor agonists, inhibit the release of both hormones. So some of the cardiovascular effects. Now, peripheral vasodilatation, there's a reduced resistance and inhibition of baroreceptor reflexes. There is inhibition of baroreceptor reflexes. Basically, your aortic and carotid body reflexes are lost. There can be orthostatic hypotension, histamine release as seen with morphine. blunting of reflexes of vasoconstriction in response to PCO2, because there is decreased sensitivity to the decreased level of PCO2 in the brain. Coronary artery disease, it is actually effective opioids because they decrease speed preload, inotropy and chronotropy. Hence they decrease oxygen consumption, left ventricular end diastolic volume, and hence they decrease the cardiac workload in these patients, and hence they are beneficiary. This protective effect on the coronary artery disease is partially mediated by increase in the centrally mediated vagal outflow, right? So it can aggravate, but in hypovolemic shock patients, because it causes decreased chronotropic inotropic effects, it can, in hypovolemic patients, it can aggravate shock. So respiratory, whenever there is respiratory depression, there will be carbon dioxide retention. This will lead to cerebral vasodilation and can lead to increase in ICD. This is a mechanism for increase in ICD. So respiratory depression, so carbon dioxide retention, cerebral vasodilation because of the carbon dioxide retention, because of vasodilation, increase in ICD. Now, some of the effects on the GI tract, the opioid receptors are distributed throughout dense distribution in the enteric plexus. So, on the stomach, it delays gastric motility and emptying and decreases the secretion of HCl. So, there will be decreased appetite because there is decreased emptying and motility, decreased appetite, and gastroesophageal reflux, GER, right? Decreased secretion of HCl. In the intestine, there is decreased propulsive activity in both the small and the large intestine. Intestinal secretions are reduced. So, as a result, there will be delayed absorption of medication. Delayed absorption of drugs, incomplete evacuation, there will be bloating sensation, abdominal distension, constipation. Ureter and urinary bladder, inhibition of the urinary voiding reflex, there's increase in tone of the external sphincter and increase in sphincter tone. As a result, there will be urinary retention. Okay. Then uterus, it restores the tone of hyperactive bladder secondary to hyperactive uterus secondary to oxytocin. So sphincter of Oddi, it contracts, and some patients with biliary colic will experience even more pain. So first of all, biliary colic, the sphincter of Oddi is contracted and they will experience even more pain when morphine is given, because this leads to contraction of the sphincter. So effect on the immune system, opioids are present on different cells of the immune system, like the neutrophils. They're said to be present, natural killer cells, and cause direct modulation of their function. They're known to suppress the HPA axis. In toto, they appear to suppress the immune function, but in the presence of pain syndromes, they appear to improve the immunity. In the sense, in the presence of pain syndromes, they actually relieve the pain, so you feel better, so the person feels that the immunity is improved. So guys, that was my class on opioids today. In brief, I dealt with the history of opioids, how it came about from the resin of the flower poppy. Then I dealt with the endogenous opioids, which are your endorphin, enkephalin, and your dynorphins. The newer one is endomorphin and your nociceptin. These opioid receptors generally they are known to, these endogenous opioids are generally released within the body and within the brain more. Also, we dealt with the opioid receptors, which are your mu, delta, and your kappa receptors, and these receptors are distributed throughout the body. The analgesia, the mode of analgesia through opioid receptors is because of supraspinal as well as spinal action. In the spinal cord, they act in the substantia gelatonosa and inhibit substance P. Supraspinal in the periaqueductal gray matter, they are known to inhibit the GABA inhibitory effects and decrease pain. And then the various other effects we talked about, other than analgesia, the effect on the respiratory system causes respiratory depression, cardiac system it causes negative inotropic chronotropic effects, protective in coronary artery disease. On the GI system it causes decreased appetite, bloating, nausea, vomiting, constipation, because it decreases gastric motility, emptying time, causes increased pyloric tone, uh, decreased fluid and electrolyte absorption, and decreased small and large intestine peristalsis, and also it increases the sphincter tone. So tomorrow at 7:30 p.m. I will be dealing with the second part of opioids. And that's about it for today, guys. So like I said previously, don't delay, subscribe right now. Let me help you all prepare for NEET PG. Use my code SASHA, get your 10% discounts. Preferably go for the 12 and the 24-month subscription. Yeah, okay guys, thank you, have a nice day, see you all tomorrow.